Hello everybody. Today we are going to discuss about cardiogenic shock. So cardiogenic shock is the common cause of mortality and management remains challenging despite advances in therapeutic options. Cardiogenic shock is caused by severe impairment of myocardial performance that result in diminished cardiac output, end organ hypoperfusion and hypoxia. Clinically, this presents as hypotension refractory to volume resuscitation with features of end organ hypoperfusion requiring pharmacological and mechanical intervention. Acute myocardial infarction accounts for 81% of patients in cardiogenic shock. So this definition and classification of cardiogenic shock. We'll go through this varying definition of cardiogenic shock according to the clinical trial. So according to the IIBP shock trial, the cardiogenic shock is defined as sustained hypotension of less than 90 mmHg lasting for more than 30 minutes or catecholamine to maintain SPP more than 90 mmHg and clinical pulmonary congestion and impaired end organ perfusion with more than one of the following criteria like altered mental status, cold clammy skin and extremity, urine output less than 30 ml per hour, lactate more than. According to IMPRESS trial, it is defined as sustained systolic blood pressure of less than 90 mmHg for more than 30 minutes or need of for vasopressors or inotropes to maintain SPP more than 90 mmHg. Then according to culprit shock trial, it is defined as sustained systolic blood pressure of less than 90 mmHg for more than 30 minutes or need for vasopressors or inotrope to maintain systolic blood pressure of more than 90 mmHg. Clinical pulmonary congestion, impaired end organ perfusion with more than one of the following criteria, like altered mental status, cold clammy skin and extremities, urine output less than 30 ml per hour, lactate more than 2. Then according to the ESC heart failure guidelines, it is defined as SPP more than less than 90 mmHg with adequate volume and clinically lab signs of hypoperfusion. Clinical hypoperfusion is identified by cold extremities, oliguria, mental confusion, dizziness, narrow pulse pressure, and lab parameters that is indicative of hypoperfusion are metabolic acidosis, elevated serum lactate, and elevated serum creatinine. So this is the PSI classification of cardiogenic shock. PSI is defined as stage classification expert consequences update. And according to this, it is divided into A, B, C, D, E, in which A means hemodynamically stable patient who is not experiencing any signs and symptom of cardiogenic shock, but is at risk for the development. B is the beginning of cardiogenic shock, a patient who has clinical evidence of hemodynamic instability, but including hypotension, tachycardia, abnormal systemic hemodynamics, but without hypoperfusion. Then C is classic, in which the patient has the clinical evidence of hypoperfusion that initially requires mechanical and pharmacological support, and hypotension is usually present. Then the D is deteriorating, a patient who has clinical evidence of shock that worsens and fails to improve despite escalation of therapy. And E is extremis, that is a patient with refractory shock of actual and impending circulatory collapse. Now, regarding pathogenesis of cardiogenic shock, the primary insult is the reduction in myocardial contractility, resulting in diminished cardiac output, hypotension, systemic vasoconstriction, and cardiac ischemia. The hallmark is peripheral vasoconstriction and vital end organ damage, which stems from ineffective stroke volume and insufficient circulatory compensation. Then compensatory peripheral vasoconstriction may initially improve coronary and peripheral perfusion. However, it contributes to increased cardiac afterloop that overburden damage myocardium. And this results in diminished oxygenated blood flow to peripheral tissues and ultimately to the heart. Systemic inflammation causes the pathological vasodilatation, releasing nitric oxide, synthetase, and Peroxynitrate, which have cardiotoxic inotropic effect. Interleukin and tumor necrosis factor alpha, they are the additional systemic inflammatory mediators that result in vasodilatation and contribute to mortality in patients with cardiogenic shock. Under normal physiological strains, the right ventricular stroke volume and left ventricular stroke volume are equal. Right ventricular failure occurs when ventricular diastolic or systolic pressure are insufficiently compensated by normal myocardial adaptive process to provide appropriate stroke volumes. Inadequate forward flow in compromised right ventricle account for end organ perfusion deficit in conjugation with increased venous pressure. So this right ventricle is less adaptive to pressure overload and more tolerant to volume overload than left ventricle. And this explains the inability of the right ventricle to tolerate severely elevated pulmonary artery pressures. As right ventricular failure results in right ventricular dilatation, the interventricular septum is displaced into the left ventricular space, causing left ventricular diastolic filling, and this compromises the left ventricular diastolic filling and further exacerbating systemic hypoperfusion. Now, regarding clinical presentation and physical examination, in setting of cardiogenic shock, the classic ACS symptom and signs are combined with the altered mental status, hypotension, arrhythmia, diminished pulses, dyspnea, peripheral edema, jugular venous distension, and orthostasis. This feature reflects an infarction involving more than 40% of left ventricle and can occur in setting of acute infarct superimposed on old MI or new massive myocardial infarction. Patient with cardiogenic shock most commonly present with full extremities and signs of pulmonary congestion. And this presentation is termed as cold and wait, which reflects the reduced cardiac index, increased systemic vascular resistance, and increased pulmonary capillary wedge pressure. So patient may also present with the euvolemic dry and cool, which indicates reduced cardiac output, increased systemic vascular resistance, and normal pulmonary capillary wedge pressure. Euvolemic presentation were more likely to have previous myocardial infarction and chronic kidney disease in comparison with those with classic cold and wet features. The under-recognized presentation of cardiogenic shock is wet and warm subtype. This represents the systemic inflammatory response syndrome reaction in conjugation with myocardial infarction and is associated with high incidence of sepsis and mortality. This patient have reduced cardiac index, low to normal systemic vascular resistance, and elevated pulmonary capillary wedge pressure. Systemic inflammatory response syndrome should be suspected by the presence of fever, elevated white cell count, and low systemic vascular resistance. 19% of patients had suspected sepsis in shock trial with high risk in a younger patient and those with low systemic vascular resistance. ACS associated cardiogenic shock patients with culture positive sepsis have 2 times risk of mortality. And systemic inflammatory syndrome is prevalent on admission in 25% of patients with STIM. Tachycardia, tachypnea, and leukocytosis, these are the independent risk factors for the mortality. Now, regarding differential diagnosis, the alternative diagnosis include other shock etiologies such as hypovolemic, distributive, and obstructive. Other types of shock may contribute to cardiogenic shock as either the main insult or in combination. Thorough medical reconciliation should be performed to discontinue agents that exacerbate hemodynamic dysfunction. Regarding initial investigation, cardiac catheterization is both definitive diagnostic investigation and guides therapeutic intervention in cardiogenic shock complicating acute myocardial infarction. Cardiac catheterization is typically preceded by the several initial investigations and non-interventional management strategies. However, cardiogenic shock is the clinical diagnosis and no investigation should delay emergent cardiac catheterization. Now regarding ECG should be ordered within the 10 minutes of the presentation. ECG findings in ACS are divided into 3 groups. ST segment elevation, ST segment depression, and non-ST segment deviation. So early ECG changes of early coronary artery occlusion and transmural infection include hyperacute T wave, which tend to be short-lived and progress rapidly to ST segment elevation. The presence of ST segment elevation in more than two contagious leads is an indication for urgent reperfusion. Transient ST segment elevation, ST segment depression, and or T wave inversion should raise clinical suspicion of ACS. And these patients should be treated with aggressive medical therapy and be evaluated immediately for early coronary angiography. New guidelines suggest that LBB is no longer an indication for urgent catheterization. In the appropriate clinical context and in the presence of present suggestive of diagnostic evidence, urgent catheterization should still be considered. Pathological Q waves are the reflection of total size MI rather than transmural extent, and their presence predict the low ejection fraction and larger. In the absence of previously described changes and high clinical suspicion of ACS, true posterior wall myocardial infarction is suggested by the following. ST segment depression in septal and anterior precordial leads, that is V1 to V4, R by S ratio more than 1 in V1 to V4, V2. ST segment elevations in the posterior leads of the posterior ECG, that is V7 to V9. If there is coexisting inferior wall myocardial infarction, there will be ST segment elevation in the inferior, that is 2-3 AV. Normal ECG is not necessarily reassuring as posterior and lateral wall are not fully represented on ECG and thus may not exclude ischemia. STEMI confer high mortality risk in ACS complicated by cardiogenic shock. It has been suggested that patients have similar 90-day prognosis if effective revascularization takes place regardless of ST segment pattern. Other findings that are suggestive of ACS include sustained ventricular tachycardia, ventricular fibrillation, atrial fibrillation, new bundle branch block, or worsening of symptomatic high degree AV block. So this is the ECG of 53-year-old male patient who presented following sudden onset of diaphoresis, nausea, sinking, and the patient was profoundly hypotensive on arrival, and this ECG reveals complete AV dissociation with junctional bradycardia. And when we perform the coronary angiography that demonstrate high-grade proximal LOD stenosis with TIMI flow of 2 and the total thrombotic proximal right ICRC occlusion. So the impeller 2.5 was inserted for left ventricular support and PCI2 LED was performed. Now regarding routine initial investigation, complete blood counts and metabolic panel should be obtained every 12 to 24 hours as they offer valuable information about oxygenation, electrolyte status, and end organ damage. Type 1 MI is caused by acute atherosclerosis as a result of plaque rupture and erosion. Frequent monitoring of the troponin may reflect extent of injury that is time dependent from initial insight. In the setting of cardiogenic shock, as in STEMI, it is not recommended to wait for the presence of elevated cardiac enzyme before emergent catheterization. Troponins are the typically trended every 6 hours starting from the initial clinical suspicion. N-terminal proBNP will be elevated during acute decompensation of heartbeat. In cardiogenic shock resulting from ACS, raised level of natriuretic peptide are associated with increased mortality. Cardiogenic shock causes reduced oxygenation in peripheral tissue that result in lower PaO2 level and elevated PCO2 level. Higher level of lactic acid can be associated with increased mortality. So the blood gas and the lactic acid should be trained to assess the response to initial resuscitation. Echocardiography may be beneficial, especially if there is clinical concern for MI-related mechanical complication. So ultimately, the patient presenting with acute right ventricular failure or left ventricular failure of suspected ischemic etiology should undergo immediate cardiac catheterization for the assessment of coronary anatomy, intracardiac pressure, valvular dysfunction, and structural impairment that often complicates ACS and contribute to cardiogenic shock. Now, regarding management, the approach to manage cardiogenic shock should be multi-mode. It includes assessment of the severity and early determination of the etiology with clinical examination and non-invasive exploration, that is clinical ECG, biological and echocardiographic test. So transthoracic echocardiography is the most useful diagnostic modality in this setting because it allows the biventricular function, valvular pathology, pericardial effusion, left and the right ventricular feeling pressure and hemodynamic assessment. Moreover, the complete comprehensive transthoracic echocardiography can provide important prognostic insight in cardiogenic shock patients. The invasive hemodynamic assessment may be required to assess the response to treatment and for continuous monitoring of cardiovascular function, especially when there is insufficient clinical improvement to initial treatment management. Management of cardiogenic shock requires close collaboration between cardiologists, intensivists, multidisciplinary discussion, and early admission to intensive care. Now, regarding monitoring, current guidelines emphasize the initiation of early basic monitoring that should be supplemented by advanced monitoring in more complicated cases and in refractory shock. Indeed, during first hour of cardiogenic shock management, evaluation of organ dysfunction by physical examination, looking for cool extremities, mottling, oliguria less than 30 ml per hour, abdominal pain and signs of encephalopathy. Then biological tests including lactate and echocardiogram. Invasive arterial pressure measurement allows early recognition, better classification, and precise phenotyping of cardiogenic shock, providing robust mortality risk stratification in this population. So lactate levels, that is pathological threshold of more than 2, and the lactate monitoring should be measured on admission and it should be repeated every 1 to 4 hours based on clinical condition in early stage of cardiogenic shock management. Elevated lactate level is associated with increased risk of mortality. Conversely, complete lactate clearance is independent predictor of in-hospital survival as early as 8 hours after enrollment in sub-analysis of dosimetry. So transthoracic echocardiography is the most useful basic monitoring modality in cardiogenic shock patients due to its accuracy to determine cardiogenic cardiac output and cardiac index with good correlation with pulmonary artery catheter data. And it allows to determine left and the right ventricular feeling pressure, pulmonary artery systolic pressure, and systemic vascular resistance. On the other hand, transesophageal echocardiography is not the first-line monitoring in this unstable patient. It should be performed under optimal safety condition, under sedation, and by expert of the technique. Of note, among advanced monitoring modality, transpulmonary thermodilation technique may be used to direct estimate of LV systolic function when TTE is not immediately available. In addition to this standard and basic monitoring, parameter derived from central venous catheter may be helpful in severe patients, like central venous oxygen saturation, which reflects the balance between supply and consumption. The veno-arterial difference in CO2 tension as a surrogate of cardiac output because it reflects the balance between CO2 production and CO2 delivery to the lung. No specific threshold is reported in current guideline, but the goal is increasing SvO2 values with serial evaluation after treatment initiation. Besides, in most patients, the pulmonary artery catheterization could be used. It is important to note that insertion and management of pulmonary artery catheter must be carried out by experts, which reinforce the need to transfer the patient to expert cardiogenic shock center. Pulmonary artery catheter directly measure pulmonary and cardiac pressure as well as central oxygen saturation and used to calculate array of hemodynamic parameters including cardiac output, cardiac index, cardiac power output, pulmonary capillary wedge pressure that is elevated is more than 80 millimeters. Then right atrial pressure, which is elevated, we can measure the right atrial pressure. Elevated right atrial pressure is more than 12 mm. Then mean pulmonary artery pressure, that is ratio of pulmonary artery pulse pressure to right atrial pressure. And we can also calculate the mean artery pulsatility index, which is the ratio of pulmonary artery pulse pressure to right atrial pressure, which is the predictor of right ventricular failure. So based on these parameters, the physician can have complete hemodynamic evaluation, and we can actually categorize the cardiogenic shock into right ventricular dysfunction and left ventricular dysfunction, right-sided congestion, which is reflected by elevated RV, left-sided congestion, which is reflected by elevated pulmonary capillary wedge pressure, and then bisided, that is both, and also we can diagnose the biventricular failure if there is a elevation of both, that is right atrial pressure and pulmonary capillary wedge pressure, and you volume. So an increasing number of studies reported the use of pre-pulmonary catheter and its association with cardiogenic shock prognosis improvement. In this regard, the recent guidelines recommended invasive hemodynamic assessment for continuous hemodynamic monitoring in acute management of patients with receiving therapy with MCS, that is mechanical circulatory support, to guide its withdrawal and to supervise the pharmacological support in patients with myocardial recovery from cardiogenic shock. So finally, in patients without recovery of myocardial end organ perfusion, advanced and invasive myocardial monitoring is useful to assess and the candidacy for and or transition to advanced heart failure therapies, including durable mechanical circulatory device and heart transplantation. So the next modality of treatment is the coronary artery revascularization. Now, regarding coronary artery revascularization, the cornerstone of the treatment that improves cardiogenic shock prognosis in acute myocardial infarction patient is emergent coronary uh, artery revascularization, that is percutaneous coronary intervention in patient with coronary artery disease. Now, fibrinolysis is ineffective once the shock has settled due to there is a reduced penetration into thrombus because of the decreased blood supply. So in this regard, so because of that, the fibrinolysis should be reserved in only very selected cases for whom the timely PCI cannot be performed. Thus, primary PCI is recommended as first line therapy according to the ECS guide. So indeed, up to 85% of the acute myocardial infarction patients presented with the cardiogenic shock are diagnosed with the multivessel and left main coronary artery disease at the time of diagnosis. So this multivessel disease being associated with high mortality compared to the single vessel disease. So we'll see what are the trials are saying about that. That means how to manage this cardiogenic shock presented with the coronary artery disease and how to manage this multivessel MI. So according to shock trial, which was published in 1999, early revascularization resulted in lower mortality from all causes at 6 months. So early revascularization is strongly considered for patients with acute myocardial infarction complicated by cardiogenic shock. Now, in 2009, the syntax trial was published in which regarding multivessel coronary artery disease, and according to this trial, the CABG remains the standard of care for patients with three vessel or left main coronary artery disease, since the use of CABG as compared with PC resulted in the lower rates of combined endpoint of major adverse cardiac or cerebrovascular event at 1. Then regarding the, should we go for single vessel disease or should we go for regarding the management of the uh, multi-vessel coronary artery disease, there are two trials, that is culprit trial, which was published in 2017, and complete trial, which was published in 2009. So, according to the culprit trial, who had multivessel coronary artery disease and acute myocardial infarction with cardiogenic shock, the 30-day risk of composite of death and severe renal failure leading to renal replacement therapy was lower among those who initially underwent PCI of the culprit lesion only than among those who underwent immediate multivessel PCI. And so, followed by that, in 2019, the complete trial was published, and according to this, so patient with STEMI and multivessel coronary artery disease, complete revascularization was superior to the culprit lesion only PCI in reducing the risk of cardiovascular death, myocardial infarction, as well as risk of cardiac cardiovascular death and uh, myocardial infarction and ischemia-driven revascularization. So the conclusion of the complete trial was contradictory to the culprit trial. So regarding arrhythmia and conduction disorder match, patients with cardiogenic shock have the high prevalence of arrhythmia and conduction disorder. And the reported incidence of atrial fibrillation is as high as 20%, with episode of ventricular fibrillation occurring 9 to 19% of patients with cardiogenic shock. In addition, 4.5 to 21% of patients will develop AV block and 4.5% will require pacemaker implantation during hospitalization for cardiogenic shock. So no specific recommendation exists regarding supraventricular arrhythmia management. So in patient with cardiogenic shock and arrhythmia, restoration of sinus rhythm and slowing heart rate, if restoration fails, can be useful to improve hemodynamic parameters. Thus, the recent AHA guidelines on acute AF management argue for immediate restoration of sinus rhythm in critically ill patient if atrial fibrillation is causing hemodynamic compromise. So, if hemodynamic situation stabilize, both rate and rhythm control are feasible. So, a choice of pharmacological treatment, amiodarone has demonstrated its efficacy for pharmacologic cardioversion in this population and seems to be the drug of choice in critically ill patients. Of note, the paradigm of safe reduction within 48 hours without anticoagulation has recently been challenged because the recent data support and increased thromboembolic risk of atrial fibrillation reduction beyond 12 hours of onset. This risk being correlated with Chadwell's. The management of high degree conduction disorder is not specific to patient with cardiogenic shock. For patient with sinus node dysfunction, second degree, third degree AV block associated with symptoms or hemodynamic compromise, atropine is the first line and is reasonable to improve AV conduction, increase ventricular rate, and improve hemodynamic parameters. So furthermore, in patients with symptoms and hemodynamic compromise who have low likelihood of coronary ischemia, beta-adrenergic agonists such as isoproterenol, dopamine, dobutamine, or epinephrine may be considered. When high-grade conduction disorder is refractory to medical treatment, temporary transvenous pacing is reasonable. Finally, the electrical storm is the life-threatening condition characterized by recurrent ventricular arrhythmia. A clinical definition of electrical storm is 3 or more sustained ventricular arrhythmia episodes separated by at least 5 minutes over 24 hours. So the management of the rhythmic storm should always include cardiologist and must take several factors into account, namely presence of underlying proarrhythmic cardiomyopathy, previously known as left ventricular function, the presence of implantable cardiovert defibrillator and hemodynamic tolerance. In addition, the search for myocardial ischemia substrate must be systematic. In cardiogenic shock patient, the immediate electrical cardioversion is always preferred. And if the patient is hemodynamically unstable. IV amiodarone is recommended as first-line antiarrhythmic therapy in electrical storm caused by structural heart disease in the absence of QT prolongation or Torsades de Pointes because of its greater efficacy for preventing recurrent ventricular tachycardia and suppressing ventricular tachycardia refractory to the other antiarrhythmic therapy. So the recommended dosage is bolus of 300 mg over 20 minutes, then repeat 150 mg bolus over 10 minutes for recurrent ventricular arrhythmia, and then infusion of 1 mg per minute until free from ventricular arrhythmia for more than 6 hours, and then we can continue 0.5 mg per minute until electrical storm resolves. So when amiodarone is ineffective as a monotherapy or for higher risk presentation, The lidocaine is often added as a second-line therapy during further amiodarone loading. Initial dose of lidocaine is 1 to 1.5 mg per kg. Of note, lidocaine is most effective on ischemic myocardium but can accumulate during decompensated heart failure or cardiogenic shock. So otherwise, specific electrical storm etiologies and myocardiomyopathy justify specific treatment such as isoprenalin for torsidosis pointers and Rubada syndrome and beta blocker for long QT syndrome. So deep sedation and intubation is very effective treatment for electrical storm and is recommended in patients with intractable electrical storm refractory to drug treatment. Moreover, implantable cardioverter defibrillator interrogation is crucial to check frequency, effectiveness, and appropriateness of device therapy. And radiofrequency ablation as sympatholysis by stellate ganglion blockage or by definitive sympathectomy should be considered in patients with recurrent episode of ventricular arrhythmia, non-responsive to medical treatment, or coronary vascular damage. Finally, in eligible patient, we can still go for heart transplantation, uh, or we can consider for the mechanical circulatory support. Now, the next is valvular disease management. The optimal management of severe valvular disease is challenging in cardiogenic shock patients because of the limited number of the studies. Several mechanisms may contribute to cardiogenic shock in the setting of decompensated valvular disease, and initial stabilization is recommended before evaluation for corrective surgery. So, cardiac surgery is the gold standard treatment in the management of symptomatic valvular disease, but its invasiveness is associated with high mortality, leading to consider alternative therapies such as percutaneous management. The role of percutaneous intervention management of valvular heart disease is increasing in cardiogenic shock patients as more and more data report its safety and good results in this severe population. However, it is important to remember that in case of valvular deterioration due to endocarditis complicated by cardiogenic shock, surgery is the cornerstone. In detail, the decompensated severe aortic stenosis. Current guidelines are very elusive but keep in place for urgent valvuloplasty as bridge to transcatheter aortic valve replacement or surgical aortic valve replacement. So management of aortic insufficiency may include atrial pacing to increase heart rate and shorten diastolic dysfunction. So this SAVR is considered the gold standard therapy, gold standard despite lack of data, but the TAVR should be considered in the selected patient. In mitral regurgitation with cardiogenic shock, surgery is indicated for primary mitral disease, but no evidence supports. The benefit of surgery in secondary mitral regurgitation, leaving a place for percutaneous approach to mitral valve. In the large observational study, Simard and the colleague reported that transcatheter H2H mitral valve repair in patient with cardiogenic shock was feasible with excellent device success rate. Finally, the severe mitral stenosis may be treated by percutaneous mitral valvuloplasty when surgery is not successful. In summary, the indication for cardiac surgery in cases of cardiogenic shock due to acute valvular disease should be personalized. When medical treatment is the first line choice, it is also seems important to reevaluate the interventional surgical indication according to evaluation of cardiogenic shock and to consider the indication before occurrence of refractory cardiogenic shock despite optimization of pharmacological treatment. Now the next is inodrops and vasopressin. In patients with acute cardiogenic shock with hypotension, early vasopressors are recommended to increase perfusion pressure of vital organs. Most often, patients with acute and chronic cardiogenic shock, but also in acute cardiogenic shock, inotropes are recommended to manage patients with hypotension and persistently low cardiac output due to decreased LV systolic function, resulting in poor vital perfusion. Moreover, the target mean blood pressure in cardiogenic shock is not well defined. So the current recommendations are based on evidence in septic shock patients, suggesting that 65 mmHg seems to be sufficient. In cardiogenic shock, the data are conflicting regarding the benefit of targeting mean arterial pressure higher than 65 mmHg. So these are the various inotropic agents that we can be used for cardiogenic shock, like norepinephrine. This main effect is vasoconstriction. It is the first line vasopressor in cardiogenic shock. Then we can also use dobutamine. It has the inotropic effect and vasodilation. It is the first line inotropic agent in cardiogenic shock. Then we can use mindrinone, which is the phosphodiesterase 3 inhibitor, and it can be used as inotropic agent. It is the second line inotropic agent in cardiogenic shock. Then levosimendan is the myofilament calcium sensitizer. It is worked as inotropic and inodilator. It is also used as second line agent in the cardiogenic shock. Now we'll see what trials are saying regarding the use of uh, inotropes. So SOAP2 trial was published, which evaluated the effect of two different regimens of first-line vasopressor in patients with shock. It compared norepinephrine and dopamine. Uh, so compared to norepinephrine, they found that dopamine was associated with higher rate of arrhythmia in cardiogenic shock subgroup and in overall population, and dopamine was also associated with higher risk of mortality. Then the Optima study was published comparing norepinephrine with epinephrine, and they reported same hemodynamic efficacy with similar effect on arterial pressure, cardiac index, but epinephrine was associated with more arrhythmia, increased heart rate, lactic acidosis. And to further this optimal trial, they have to terminate it prematurely because of the increased incidence of shock in cardiogenic shock patient, refractory shock in cardiogenic shock patient receiving epinephrine. Then the Doremi trial was published, which uh, uh, which compared Mendrenone and dobutamine. So the primary composite outcome did not differ between Mendrenone and dobutamine group. And the next, the survival trial study was published. In that, they studied 1,227 patients suffering from acute and chronic cardiogenic shock, and they were randomized to receive either levosimendan and dobutamine, and there was no difference in the mortality, but there was uh, then the next is the management of acute respiratory failure in cardiogenic shock. The incidence of acute respiratory failure in cardiogenic shock patient ranges between 50% to 88%, with more than 80% of patients with cardiogenic shock requiring respiratory support. So cardiogenic pulmonary edema is the backward failure due to left ventricular systolic and diastolic dysfunction. In addition, intrapleural pressure seems to be the major determinant of respiratory impairment. So during respiratory failure, active respiratory muscle contraction induces negative pleural and increasing venous return and RV and LV failure. So other factors that contribute to the further impairment in gas exchange. Indeed, concurrent inflammatory response conduces to the development of alveolar edema by changing vascular membrane permeability, while acute kidney injury favors fluid retention. Though the compensatory increase in respiratory drive in response to hypoxia, hypercapnia, metabolic acidosis can further redirect cardiac output towards respiratory muscle, perpetuating myocardial ischemia, tissue hypoperfusion in cardiogenic shock patients. So the first aim of the ventilatory support with the positive pressure ventilation is to improve gas exchange and to reduce the alveolar interstitial edema and enhance the alveolar rhythm. It leads to the better systemic and myocardial oxygenation and the reversion of hypoxic pulmonary vasoconstriction. So positive pressure ventilation decreases the myocardial oxygen demand by decreasing myocardial wall tension. In addition, this positive pressure ventilation also decreases the work of breathing and reduces oxygen consumption of the diaphragm. So finally, the positive pressure ventilation leads to the favorable hemodynamic effect by reducing RV, LV preload and LV afterload, thereby improving cardiac output. So recent studies suggested that the positive pressure ventilation with non-invasive ventilation reduces the risk of invasive mechanical ventilation. So non-invasive ventilation represents the cornerstone in the management of cardiogenic pulmonary edema, but its place in the cardiogenic shock management is more questionable, mainly due to hemodynamic instability and consciousness impairment. So two main modalities of NIV are used in ICU, that is CPAP and BiPAP with P. So minimal starting setting of ppv should be 5 to 10, adjusting according to the saturation. Although CPAP is a simpler technique, BiPAP could increase tidal volumes and seem to be preferable in patients with hypercapnia, chronic lung disease, and severe respiratory failure. Finally, HFNC shows the improvement in the oxygenation, providing inconstant peak effect between 5 to 7. When invasive mechanical ventilation is needed, the patient with cardiogenic shock should benefit from early intervention. A recent study highlighted that each 1 hour delay in invasive mechanical ventilation initiation was associated with 30-day mortality. However, particular attention in early intervention should be paid to cases of severe right ventricular dysfunction or TAP. In these cases, positive pressure ventilation has to be used only when necessary, optimizing preload and MAP with the vasopressor is needed, and consider awake intubation if tamponade and constriction. In cardiogenic shock patient, no data supports the superiority of any specific mode. So importantly, spontaneous breathing modes as a positive support ventilation could increase myocardial oxygen consumption if spontaneous breathing is not fully supported, making this ventilation mode less suitable to cardiogenic shock acutes. The PEEP level is set at 5 centimeters of water and gradually increased, taking into account respiratory and hemodynamic risk of excessive PEEP. FiO2 should be titrated between 92 to 90. Respiratory rate is adjusted to limit acidosis as hypercapnia could worsen RV dysfunction. And tidal volume should be more than 9 ml per kg and it is associated with higher mortality. So the tidal volume should not exceed 6 to 8 ml per kg of ideal body weight. Now the next is regarding renal replacement therapy. Acute kidney injury occurs in up to one half of the patient with cardiogenic shock, and up to 20% of these patients will require RT. AKI is the strong predictor of the poor outcome, regardless of the etiology of cardiogenic shock. Indeed, patients with indication for RRT have twofold increase in the risk of in-hospital mortality, along with higher risk of long-term dialysis when compared with those with no need for RRT. So, in a recently published study, age, lactate, hemoglobin, and pre-admission good diuretic use, baseline EGFR were identified as most important clinical predictor of poor outcome in patients with cardiogenic shock requiring RRT. In retrospective analysis of 142 patients managed with post-cardiotomy cardiogenic shock complicated with AKI, the early initiation of high-volume continuous venous hemofiltration resulted in improved outcome with lower in-hospital and 30-day mortality rate when compared to patients undergoing low-volume hemophilia. Importantly, as a patient with the cardiogenic shock do not tolerate acute fluid shift as observed in patients with intermittent hemodialysis, so the continuous RRT is the most commonly used strategy. Then the next is acute mechanical circulatory support. In cardiogenic shock, short-term acute mechanical circulatory support should be considered when urgent hemodynamic stabilization is needed despite ongoing medical therapy. So to allow for heart recovery and end organ protection, or to bridge to transplant and long-term mechanical circulatory support, that is bridge to bridge or bridge to decision strategy. So various trials are published regarding to that. The first one is IBP shock trial, which compared IBP with other MCS device like Impella, and they show no significant difference in mortality. Then ECLS shock trial, it is conducted by Hailey and colleagues on 417 patients with AMI complicated by cardiogenic shock, and there was no difference on death from any cause at 30 days. Moreover, the use of VA ECMO was associated with increased side effects like bleeding. Then there was a Euroshock trial which was published in 2023. The Euroshock trial aimed to determine if early use of veno-arterial ECMO could improve the outcome in patients with persistent cardiogenic shock following primary PCI. But due to limited number of patients recruited to the trial, no definitive conclusion are made. Then ECMO-CS trial was published in 2023, and this extracorporeal life support is increasingly used in the treatment of infarct-related cardiogenic shock, despite lack of evidence regarding its effect and mortality. So in patient with acute myocardial infarction complicated by cardiogenic shock with planned early revascularization, the risk of death from any cause at 30-day follow-up was not lower among patients who received this extracorporeal life support therapy than among those who received medical therapy alone. Then in 2024, danger shock trial was published. So in this, the routine use of microaxial flow pump with standard care in treatment of patient with STEMI related to cardiogenic shock lead to lower risk of death from any cause at 180 days than the standard care. And the incidence of adverse event was higher with the use of microaxial fluid. So we'll have a look on the ESC guidelines, which was published in 2023. So we'll see what they're saying about cardiogenic shock. So immediate coronary angiography and PCA of infarct-related artery is recommended in patient with cardiogenic shock complicating ACS, and it has class of recommendation 1, level of evidence B. Emergency CABG is recommended for ACS-related cardiogenic shock if PCA of infarct-related artery is not feasible. It has class of recommendation 1, level of evidence B. In cases of hemodynamic instability, emergency surgical catheter-based repair of mechanical complication of ECS is recommended based on hard team discussion. It has class of recommendation 1 and level of evidence C. Fibrinolysis should be considered in STEMI patient presenting with cardiogenic shock if PCI strategy is not available within 120 minutes from time of STEMI diagnosis and mechanical complication have been ruled out. It has class of recommendation 2A, level of evidence C. In patient with ACS refractory cardiogenic shock, short-term mechanical circulatory support may be considered. Class of recommendation 2B, level of evidence C. The routine use of IABP in ACS patient with cardiogenic shock and without mechanical complication is not recommended. Class of recommendation 3, level of evidence B. Thank you guys for attention.